Hello, my name is Nikki Rowe, and in a minute you're going to meet one of my colleagues, Kim Jones. We're both Academy Admiral nurses with Dementia UK. Thank you for attending this presentation. It's so nice to see so many people here. We're going to be discussing sexuality, disinhibitions, and intimacy in dementia. In this presentation, we're going to remind ourselves of personhood, body image of older adults, and how this relates to self-expression. We will also be exploring what disinhibition means, consent and capacity, and be really clear about safeguarding. We hope that you'll feel comfortable and safe to share your ideas and discussions using the chat box throughout. This is obviously a recording, but there will be time at the end of the presentation to come back and reflect on the chat box input. Thank you. So the aims of our presentation is for you all to feel comfortable and enabled to address sexuality and dementia, and to understand and respect personal lifestyle choices and how this relates to person-centered care, to have an open and safe discussion and be clear about how to positively respond to perceived sexual disinhibited behaviours, and to understand best practice and safeguarding procedures. You may be familiar with Kitwood's flower of psychological needs. If not, Tom Kitwood was the first in his field to look at people diagnosed with dementia and see beyond the diagnosis. He did this using a person-centered approach and developed a model of psychological needs that we use today. Kitwood suggests that every person needs love, which is at the centre, and then there are 5 petals which depict inclusion, attachment, comfort, identity, and occupation. This is what Kitwood describes as personhood. Personhood is recognising that we are all different, and as individuals, we all have individual needs. This is why a one-size approach does not fit all. Looking at Kitwood's model, why do you think a person living with dementia may seek others for intimacy? And I'm going to give you a couple seconds to think about that and pop your answers in the chat box. It may be because they are scared or disorientated, especially if they are in an environment that they don't recognise. They may be seeking company from others, such as things like hand holding and touch because that feels nice. They may be expressing a need for comfort and love, especially if someone looks familiar or similar to someone that they do love. Or they may be bored and frustrated, and many people still have a need for intimacy and sexual touch. I'm now going to pass you over to Kim.
Hi, I'm Kim, and what we're going to start to look at and discussing is self-expression. So, I want you to think, how do people express themselves in everyday life? Self-expression is our shop window of who we are, our choices, sexuality and preferences. Can you think of a way that you express yourself? Could be clothing, hairstyles, jewellery, tattoos, and much more. Now, I want you to think, does this change as we get older? Sometimes it can change due to social norms, our bodies change over time, and there's a natural part of maturity and aging. But then, sometimes the way we express ourselves doesn't change. How does the media portray older adults living with dementia? What we generally see is a person depicted as normally frail, in bed, media using the terms such as suffering with dementia, but we never see a person living with dementia described as having a need for intimacy or a person who is able to self-express. let's ask ourselves the question, do older people feel desirable? Do they still have sexual desires? Do they still want sex and have sexual needs? And might they have a need for sexual gratification? What do you think? Are people living with dementia any different? Please feel free to use the chat box to share your views. Whilst writing in the chat box, we're going to move on to LGBTQ+. Can you tell me what that means? So LGBTQ+ means lesbian, gay, bisexual, transgender, queer, and then including others. We know there will be members of the LGBTQ+ community who are living with dementia. At Dementia UK, we have appointed our own LGBTQ+ consultant Admiral nurse, and you'll be hearing from him after our presentation. I'm going to pass you back over to Nikki.
Thanks, Kim. So what does disinhibition actually mean? Disinhibition is acting without inhibitions and without regard for consequences. Disinhibition often includes inappropriate actions that go against the social norms, and that comes from Kelly 2023. Can anybody think of an example of disinhibited behaviour? Pop that in the chat box now if you can. This may be something quite basic, like removing clothing in a supermarket because you are hot, or it may be something much more, like sexual touch and gratification. So why might this be happening? The causes of disinhibition may be physical, emotional, environmental, and much more. Often a person living with dementia can easily misinterpret social clues. So if you have had a dementia and you were hot in a supermarket, why would you not remove your clothing? Another example of this could be a carer asking, "Do you want to get into bed?" You can see how an innocent sentence could be misinterpreted by somebody with a disease of their brain. There are many other reasons why someone may present with disinhibited behaviour. This could be a symptom of delirium, which we will discuss more fully on the next slide. It could also be effects of medication, a change of environment, or something much more basic, like the need to use the loo but can't find it or can't manage clothing. There may be psychological and emotional reasons, such as someone being isolated or bored with a lack of occupation and purpose to their day. Think back to Kitwood's flower. We sometimes hear terminology and labelling for these symptoms, wording such as dirty old man. However, this is really judgmental and often untrue. Having an intimacy or a sexual need is not dirty, and labelling can be really dangerous and discriminatory. So what is delirium? Let's have a look at that. Delirium is a worsening or change in a person's mental state that happens suddenly. The person may become confused or may be more confused than usual. Delirium can be distressing to the person and those around them, especially when they don't know what's happening to cause these changes. Delirium is an acute change in a person's presentation and can be treated, managed, and in some cases reversed. There are three subtypes of delirium: hypoactive delirium, hyperactive delirium, and mixed delirium. As the name states, hypoactive delirium is when a person becomes sleepy or drowsy, which is not usual for them. This can disable them from doing their normal every day-to-day activities. Hypo means low, so this is a good way to understand how a person may present. By knowing the person, you will know what is normal and usual for them, and that's the key to seeking out why there has been acute change in their presentation. Hyperactive delirium is when a person has an acute presentation where they will become more animated, agitated, and distressed than what is normal for them. This will present with the opposite symptoms from hypoactive delirium. Mixed delirium is when a person presents with some symptoms of both hyper and hypo delirium intermittently. This can be much harder to diagnose due to the mix in presentation. With all subtypes, the key is to ascertain the root cause of the delirium and ensure actions are taken. It is imperative that we understand that this is treatable and can be managed, and it's not a normal part of the dementia journey. So can delirium affect sexuality and disinhibitions? It's possible that a person living with dementia with symptoms of hyperactive delirium can express their symptoms as disinhibitions. This may be caused by an infection such as a urinary tract infection or a chest infection, and the person living with dementia may appear more agitated and have fluctuations in their ability. They may present more disorientated than normal and display disinhibited behaviours due to this. Behaviours such as moving clothing in public or something much more socially out of the norm, like masturbating, may suggest that a delirium, if that is not usual for that person. I'm going to now pass you over back to Kim.
Thank you, Nikki. So we're going to look at consent. So what is consent? The Royal Marsden 2024 says that consent is your freely given agreement to what is proposed based on a full understanding of what is to happen. So considering what I've just read, how do we know what consent looks like in a person living with dementia? Please use the chat box or take the time thinking about it. For example, if a person living with dementia is smiling, are they given their consent? And also, why may a person living with dementia not recognise the need for consent? As discussed previously, that could be misinterpreting other people's behaviours, belief in traditional values, where the wife must obey. Now we're going to come on to the Mental Capacity Act in safeguarding. I would like you to consider, if both partners have capacity to consent to sex, what do we do? What do we do if one of the partners or both of them live in a care home, for example? You can use the chat box. What we should do is provide a dignified, private and safe space and leave them to it. But what if one of the partners has capacity to consent to sex and the other does not? What do we do? What would we do if a couple has been married for 40 years? Does capacity to consent matter? The Mental Capacity Act states, if you lack capacity to consent to sexual relations or marriage, there is no best interest decision to be made. Sex, where one person lacks capacity to consent, is rape. Rape cannot be in someone's best interests. What does safeguarding mean? The Care Quality Commission, or CQC, state that safeguarding means protecting people's health, well-being and human rights, and enabling them to live free from harm, abuse and neglect. If you suspect any of this is occurring, that is when you safeguard. We are not the decision makers. You suspect something, you raise a safeguarding. The safeguarding team will then process your concern. They are the decision makers and they have their own process to follow. Safeguarding is everyone's concern. So if you raise a safeguarding, it is your responsibility to follow it up if you're a professional. How do you safeguard? You follow your local policies and guidelines. You can usually just Google safeguarding for those that aren't professionals. So safeguarding in my area, and then the process will come up with your local authority. Now we're going to move on to the Mental Capacity Act. So there are 5 principles of the Mental Capacity Act. We strongly advise you to attend your local training on this issue, as it's a brief overview and it's nothing in depth. Capacity is decision specific. Can the person consent to an enema, for example, is very different to can they consent to their house being sold. So, number 1, we always assume capacity, unless proven otherwise. Number 2, take all practicable steps to help a person make their own decision. What does practicable steps mean? It doesn't mean that we ask a question, they don't answer, and then they're deemed to have no capacity. It means this has to be a thoughtful process. Do they need a different language? Do they need an interpreter? Do they need things written down, a quiet room, picture form, etc.? Have you done everything possible to help the person understand? Number 3, people can make unwise decisions. Just because we don't agree or we wouldn't choose to do it doesn't mean that they don't have capacity. It means they're able to make their own informed choice, whether wise or unwise. Number 4, when a person is deemed to have no capacity, then decisions can be made in that person's best interest. However, this is in connection with care and treatment, and this is key to proper capacity assessment and best interests. So if the above hasn't been done, this part can't happen. And number 5, always use the least restrictive options first. So before the act is done or the decision has been made for them, we have to have regard to whether the person and the purpose for which the issue or the best interest decision has been made can be achieved using any least restrictive option. One in a way that is less restrictive of the person's rights or their freedom. And they need to be proportionate. We have to mention fluctuating capacity. So for those individuals who are known to have fluctuating capacity, the advice would be to get to know the person. For example, if the person has a Lewy body dementia diagnosis, we know that at certain times of the day, they might be more able to have a more important conversation. That's when you have those conversations, when the person is at their best. We need to talk about DOLS, or deprivation of liberty. What is it? So a deprivation of liberty is an order used for someone in a hospital or a care home who must lack capacity and cannot consent to their care or treatment. If you are in hospital or a care home and the doors are locked and they are not free to leave, then a DOLS must be put in place. In hospital, an urgent authorisation form is usually sent, which lasts for 7 days. This cannot be extended beyond 14 days. So it's good practice to use a standard authorisation form, put that in at the same time as your urgent. So for what reason, you can use the chat box, would somebody living with dementia who lacks capacity and who is in hospital and they're not free to leave, why would they not be subjected to a dose? Does anybody know? I'm going to give you a couple of seconds. And the answer would be when the person meets the criteria for detention under the Mental Health Act. If anybody is unsure whether someone is being deprived of their liberty, then there is something called the acid test. That's led by a court judgment by Lady Brenda Hale. And the acid test is the person free to leave and are they under continuous supervision and or control? Point to note that in July 2018, a new amendment was passed to the bill that LPS or Liberty Protection Safeguarding will be taken over the doors. Currently, that is on an indefinite pause within our current government, but we do need to make a nod to it so you're aware, because you might hear the term Liberty Protection Safeguarding or LPS, but currently that is on a pause and it is doors that we use. There were some significant differences, but if we go right back to basics of the doors, we will still be okay. So I'm going to pass to Nikki now.
Thanks, Kim. I think it's really important to acknowledge that family members may need support during this time. Family members will often struggle to understand or accept that their loved ones may have a sexual need, and this is such a taboo subject within our everyday life. We have looked at some ways in which family support can be given during this time. Firstly, acknowledging that it may be a really difficult conversation for them and possibly for you. It's okay to feel a bit uncomfortable at first, and acknowledging it may be the way to break the ice. Family members may need some education and clear, sensitive, up-to-date understanding of terminology. Don't forget, terminology changes over time. So the language that we may use today may be very different from someone from another generation, particularly surrounding intimacy and sexuality. Family values, cultures and traditions may exacerbate that discomfort. For example, marriage vows used to say obey, which may need to be thought about, particularly when looking at consent that Kim mentioned earlier. For previous generations, there was no culture of divorce, and generational and cultural understandings have changed. Also, many families will come with their own prejudices, thoughts, feelings, and experiences. Some may be much more open-minded than others. Families may also feel grief at a person living with dementia becoming a different person to them. This could bring sadness, grief, or they may not have had a close relationship in the first place. Families will often feel shame or embarrassment at a loved one using sexualized language or behavior in public, and this often breaks the social norms. This is really common and needs to be respected and thought about. Some family members may express jealousy if attention is paid towards another person. For example, if a husband walks into a care home and sees his wife kissing another man. Many families have historical baggage, and this could be quite serious, such as abuse, affairs, secrets, etc. And this can cause a mix of emotions for families. It's also really important that we look after ourselves in these situations. So you might be feeling embarrassed, uncomfortable, or come with historical, cultural, or societal values or baggage of your own, and that's okay. This can be complex, and it's definitely a taboo nature of some of the issues that we've discussed today. And this can be a real challenge even to the most open-minded of us. So I would say just be kind to yourself. Use any support networks already in place, such as professional supervision or employee assistance, if that's available to you. Dementia UK helpline is also available to you as a source of support if required. I'd like us all to take a couple minutes to reflect on this session. Has there been anything that we've discussed today that will make you think differently? What would support your practice going forward? What will you take away from today? Please use the chat box. We'd love to hear those. Thank you all so much for listening. And if anybody has got any questions or comments, please put them in the chat box, and Kim and I will be available to talk to you about those now. Thank you very much.
Thank you.